Lung cancer is a very high-yield topic. Cancer overall is the second leading cause of death after heart disease. Among all cancers, lung cancer is the leading cause of cancer-related death worldwide. As shown in the table, in terms of incidence, lung cancer is the second most common cancer in both men and women. However, when it comes to mortality, lung cancer ranks first. Cancer develops when a cell has driver mutations that allows it to divide uncontrollably and to invade surrounding tissues. These mutations can be either inherited germline mutations or acquired somatic mutations that result from exposure to environmental carcinogens. These environmental factors cause DNA damage that results in somatic mutations. We will discuss somatic driver mutations later, but here are the common ones seen in adenocarcinoma of the lung: EGFR, ALK, and KRAS mutations. Now, what are these environmental risk factors that contribute to lung cancer? The three most important risk factors for lung cancer are smoking, radon, and asbestos. Other environmental and occupational exposures include arsenic, chromium, nickel, air pollution, chemotherapy, and ionizing radiation, such as radiotherapy and radiographic imaging. Chronic lung diseases like COPD, pulmonary fibrosis, and silicosis also increase lung cancer risk. They cause chronic inflammation, leading to more cell division and a higher chance of mutations. Now let's talk about the most significant risk factor: tobacco smoking. Tobacco smoking is the most common risk factor for lung cancer, accounting for about 85% of cases. The remaining 15% occur in non-smokers. So what causes lung cancer in non-smokers? In these cases, risk factors include secondhand smoke, radon, air pollution, exposure to metals like chromium and arsenic, as well as chemotherapy, radiotherapy, and chronic lung diseases. Moreover, lung cancers in non-smokers are more common in women and are predominantly adenocarcinomas. At the molecular level, these cancers often feature driver mutations, such as EGFR mutations and ALK gene rearrangements, whereas KRAS mutations are more commonly seen in smokers. It is not nicotine that causes lung cancer. Rather, it is the carcinogens, such as polycyclic aromatic hydrocarbons, that are produced during tobacco smoking. In fact, cigarette smoke contains over 60 different carcinogens. The risk of lung cancer increases with both the number of cigarettes smoked per day and the total duration of smoking. But how do we quantify this risk? We use a measure called pack years. A pack year is calculated by multiplying the number of packs of cigarettes smoked per day by the number of years a person has smoked. Since one pack contains 20 cigarettes, you can calculate the number of packs per day by dividing the number of cigarettes smoked per day by 20. For example, if a patient smokes 10 cigarettes a day for 30 years, they have 15 pack years of smoking. Studies have shown a dose-dependent linear relationship between pack years and lung cancer risk, which is why this measure is also used in lung cancer screening. Smoking cessation reduces the risk of lung cancer, but not to a non-smoker level. Former smokers still carry a higher risk than those who have never smoked. For patients with a smoking history of 20 pack years or more, either current smokers or former smokers who quit within the last 15 years, annual lung cancer screening with low-dose chest CT is recommended. Screening should begin at age 50 and continue until age 80. Early detection through lung cancer screening can catch the disease at an earlier stage, significantly improving survival rates. In fact, screening has been shown to reduce the relative risk of death from lung cancer by 20%. Chest CT is preferred over chest X-ray because it has a higher sensitivity, meaning it is better at detecting early lung cancer. In a screening test, a highly sensitive test is used because you can rule out the disease when the test is negative, a principle sometimes remembered by the mnemonic SNOUT, sensitive test, when negative, rules out disease. Radon is the second leading cause of lung cancer after tobacco smoking and the most common cause of lung cancer in non-smokers. Radon is a colorless, odorless, radioactive gas naturally found in soil. It is produced from the radioactive decay of uranium. While radon typically disperses into the atmosphere, it can accumulate in enclosed spaces with poor ventilation, such as basements. People who spend significant time in basements are at higher risk of exposure. Additionally, underground uranium miners face an increased risk of lung cancer due to prolonged radon exposure. Radon is unstable and undergoes nuclear decay, emitting radioactive alpha particles. These ionizing radiations can damage DNA in the respiratory epithelium when radon is inhaled, making lung cells more susceptible to mutations. Now let's consider a case. A 60-year-old patient smoked 10 cigarettes a day for 20 years. He quit smoking 8 years ago and now spends a lot of time in his basement pursuing his hobby. What are his risk factors for lung cancer? The answer is smoking and radon exposure due to prolonged time spent in the basement. Does this patient meet the criteria for lung cancer screening based on his smoking history? The answer is no. His smoking history is 10 pack years, while lung cancer screening is recommended for those with at least 20 pack years of smoking history. Asbestos refers to a group of fibrous minerals that were widely used in industries such as shipbuilding and home insulation. When asbestos-containing materials are disturbed during activities like demolition, renovation, or mining, the microscopic fibers can become airborne and easily inhaled. Once inhaled, these asbestos fibers can lodge in the lung tissue, causing chronic inflammation and scarring. Over time, this persistent irritation can lead to mutations in the lung cells, ultimately increasing the risk of lung cancer. In patients exposed to asbestos, bronchogenic carcinoma is more common than mesothelioma, and adenocarcinoma is the most common type of lung cancer in these cases. It is important to note that smoking and asbestos exposure have a synergistic effect on lung cancer development. Active smokers have a 10-fold higher risk of lung cancer compared with non-smokers who have about a 1% lifetime risk. Asbestos exposure alone increases this risk by nearly 6-fold. However, when combined with smoking, the risk dramatically increases, resulting in a 60-fold higher risk of lung cancer. On the other hand, mesothelioma is not associated with cigarette smoking. As we have seen earlier, cancer develops when a cell acquires mutations that allow it to divide uncontrollably and invade surrounding tissues. The mutations that contribute to the acquisition of these cancer hallmarks are referred to as driver mutations, while other mutations that don't affect the cell's behavior and have no phenotypic consequence are termed passenger mutations. In lung cancer, somatic driver mutations occur as a result of environmental carcinogens causing DNA damage. This damage can either activate oncogenes or inactivate tumor suppressor genes, ultimately leading to malignancy. To better understand this, let's revisit some cell biology. In the cell cycle, proto-oncogenes are the genes that normally promote cell division, while tumor suppressor genes act as the brakes, for example, stopping the cell from dividing when DNA damage is detected. DNA repair genes work to fix any damage, and apoptotic genes trigger programmed cell death, for example, when the DNA damage is irreparable. These 4 classes of genes, proto-oncogenes, tumor suppressors, DNA repair, and apoptotic genes, are the main targets of cancer-causing mutations. In lung cancer, the most commonly altered tumor suppressor genes include P53, RB1, and P16. And the most common oncogenes associated with lung cancer include KRAS, members of the MYC family, HER2, BCL2, and EGFR. Specifically, activating gain-of-function mutations in oncogenes such as LK, EGFR, and KRAS are frequently observed in adenocarcinoma. Conversely, amplification of the MYC oncogene and inactivating or loss-of-function mutations in tumor suppressors like TP53 and RB1 are often found in small cell lung cancer.